Our last speaker is Dr. Sean O'Leary, an associate professor from the University of Colorado, Denver. And Dr. O'Leary is going to be talking about strategies for improving healthcare providers' communication about vaccination. So welcome, Sean.
Thank you. Can you hear me?
Yes.
Great. Okay, so I think I'm going to be expanding a bit on some of what Dr. Willin talked about in his outstanding presentation just now. So I have no disclosures. Medical providers clearly play an important role in recommending vaccines. Over the last few decades, in study after study, the quality and presence of a medical provider's vaccine recommendation has been associated with increased vaccination uptake. And this, of course, makes sense as medical providers are consistently shown to be among the most trusted individuals in society. Today, I'm going to talk a bit about some of the recent evidence about how providers can effectively communicate in the patient-provider encounter. And while this is certainly important, I want to reiterate that provider-patient communication is only one small piece of a much larger puzzle. It takes many different strategies to achieve and maintain high vaccination coverage. So with this slide, I want to point out what Dr. Willin pointed out as well, what many of us in the world of vaccination have recognized for many years, that the acceptance of vaccines exists on a spectrum, and parents and patients' concerns vary widely. The vast majority of parents and patients are represented on the middle and left side of this slide. While people who refuse all vaccines certainly tend to be vocal about it, they represent a relatively small proportion of the overall population. And I mention this because the communication techniques I'll be discussing, I tend to recommend using them for the middle and left side of this figure. Individuals who are strongly anti-vaccine, for example, in an encounter where they're trying to convince the provider that vaccines are bad, are likely not convincible in a single patient encounter. In these circumstances, I recommend that providers simply state their belief in the importance of vaccines and offer to keep a dialogue open. If not, these types of encounters can easily turn into arguments, leaving little time to discuss other health and safety issues. So what is the evidence regarding face-to-face conversations about vaccines? The Cochrane collaboration, which synthesizes evidence, has examined this question twice in the last decade, and essentially what they've concluded is that the evidence is not very good for any specific technique. So why don't we have better evidence about how to communicate with parents and patients about vaccines? While we've done extensive research on parents and patients' knowledge, attitudes, and beliefs, there's been relatively little research on which communication techniques actually change behavior. And the way I like to put it is that for too many years, we've been focused on the what more than the how. So what do I mean by that? So by the what, I'm talking about the facts around vaccines, things like what are the ingredients in vaccines? What are the diseases we're preventing, the immunology of vaccines? In vaccine conversations, it's necessary that a provider knows these facts, but these facts alone are often not sufficient for parents with questions about vaccines. So by the how, I mean, what is the best way to convey information so that a parent or patient who's already resistant will be receptive to the information that a provider shares? The conventional wisdom has been improve parents' knowledge and they'll make the right decision. But this approach assumes human decision-making is always rational, which I think we can all agree it's not. So investigators are now focusing on developing interventions to improve vaccination, focused on how people actually think rather than how we think they ought to think. So with this next slide, I want to talk about a landmark observational study performed by investigators in Seattle. So parents and patient providers were video recorded at well-child visit encounters, and they were told that the investigators were examining communication techniques related to preventive care in children rather than the vaccine conversation specifically, so as not to impact that portion of the discussion. By administering a broad survey prior to the visit, the investigators were able to identify, they're able to oversample vaccine hesitant parents. So they wanted to understand what in the vaccine conversation predicted uptake of vaccines. And it turned out that the best predictor of vaccination uptake were the first words out of the provider's mouth. The providers broke these conversations down into what they termed a presumptive format and a participatory format. A presumptive format takes the form of a declarative statement presupposing parents will vaccinate. Sarah gets 3 shots today. A participatory format involves an open-ended question offering parents decision-making latitude. For example, how do you feel about shots today? It turns out that the differences in these two approaches were striking. When providers opened the conversation in a presumptive format, parents resisted the recommendation about 26% of the time. On the other hand, when providers opened the discussion in a participatory manner, parents resisted the provider's recommendation 83% of the time. And this finding held true for both hesitant and non-hesitant parents. Why might this be? So it turns out that as humans, when we perceive a decision to be complicated, as many parents perceive the vaccination decision to be, we tend to have what's called a status quo bias or a default bias, meaning we go with what's expected of us or what's normal. By assuming a presumptive tone, providers are conveying that vaccination is the norm. This is what we do. So parents are less prone to resist. In many cases, parents may actually be more comfortable with the decision to vaccinate after a presumptive recommendation, since a participatory recommendation may leave them questioning whether they've made the right decision, whether they've done the right thing for their child. This approach has also been shown to be effective in a randomized trial conducted by Brewer et al. For increasing uptake of HPV vaccine. I now want to introduce the communication technique of motivational interviewing. Essentially, motivational interviewing is a framework for communication that flips the traditional patriarchal approach of medicine, where the patient does a health behavior change because the provider tells them to do it, to a guided conversation driven by the patient's own internal motivations. The provider guides the conversation so that the patient recognizes the importance of the behavior change because of the patient's own internal motivations. I personally really like it because it's adaptable to just about any topic to improve communication. So in this study that I'm showing here, we wanted to test the impact of MI on HPV vaccination rates. We randomized clinics to either a control arm or to an intervention arm that included several components, with motivational interviewing training being at the center of the intervention. We found that providers' self-efficacy for changing parents' minds about HPV vaccine improved, and more importantly, we saw an almost 10% increase in HPV vaccine initiation in intervention clinics compared to control clinics. So what does motivational interviewing look like? I should be clear that MI can be a long process, but for the vaccine conversation, it doesn't have to be. Based on provider feedback, we've identified these 5 skills as the most important for the vaccine discussion. Our goal is to make these conversations effective, but also efficient. I'm going to demonstrate a brief example. After introducing the HPV vaccine in a presumptive manner, the provider meets resistance. This conversation will demonstrate the techniques I just showed you. So you seem to have concerns about the HPV vaccine. Well, that's perfectly understandable. I've had a number of questions about this one. Would you mind sharing what your particular concerns are? Parent says, well, I've heard that it's a vaccine to prevent a disease that's transmitted by having sex, and she's a long way from having sex. Okay, so a common concern about HPV vaccine. So then the provider reflects back. So I can hear that you're concerned that she's too young for the HPV vaccine because HPV is transmitted by sex. Well, I completely get that. She's only 11 after all. I've thought a lot about this. Is it okay if I go over how I've come to think about this vaccine? So I want to call that one out as well. So that's called asking permission to share, sometimes called elicit, provide, elicit. And simply by asking that one question, in most cases, a provider is, instead of asking the question, just going to jump into why the patient is wrong or the parent is wrong. By asking the question, you are creating an environment where the patient is, or the parent is, slightly more receptive to what you're then going to say. Now, some parents will say, well, no, I really don't want to talk about it, and that's fine, but that's really the exception. The vast majority of parents will say yes. So then the provider can say, well, I used to think of this vaccine as something to prevent a sexually transmitted disease, but realized it's really about preventing cancer. Almost everyone gets this virus, so I think it's important for everyone. If she were my daughter, I wouldn't hesitate to recommend this vaccine for her, and most of my patients now are getting the vaccine. Having said that, this is a decision only you can make. What do you think? And the last one I want to point out is the autonomy support. By offering autonomy support, similarly, you are coming around to the side of the parent or the patient so that they are more receptive to the information that you're sharing. So with some teams in Colorado, with teams here in Colorado and also in Washington State, we're currently conducting a randomized trial training providers in motivational interviewing for addressing the infant series of vaccines. We're evaluating the trainings as we go along, and this is a quote from an experienced pediatrician taken several months after the initial training. So what she told us was that asking permission to share had really been a game changer. It had really changed her conversation. This was after having years and years of vaccine discussions. In closing, I just want to mention that there are other groups around the world examining the use of MI in vaccine conversations with some encouraging results from a group in Canada specifically. And I want to point out that there's no magic to MI. There's certainly other potentially effective communication frameworks out there, as Dr. Willin shared. But I really like MI as an approach because once a provider becomes familiar with its use, it can be easily adapted to address many different concerns in a way that's mutually beneficial. Patients and providers can feel that their concerns have been heard, and providers can feel better that they have communicated the facts without getting into an argument. And I will end there, and I think we're moving into the Q&A session now. So thank you.